So, ladies and gentlemen, mesdames, messieurs, bienvenue, welcome. It's a pleasure to have you here. If you're here for Marketing 101, you're in the wrong room. But if you are here for learning more about practical lessons on improving health outcomes for people experiencing homelessness, then you're in the right room. Okay, good. And this is a topic that is close to my heart. My name is Sam Watts. I'm going to have the privilege of being your moderator for the next 90 minutes or so, which really means that I'm going to be sitting on the side encouraging you to listen to some experts. And we're going to hear from 3 different groups, roughly 20 minutes each. They're going to talk about their perspective on this particular topic, and then you will have an opportunity to ask questions. And when we do ask questions, I'm assuming we have a microphone for in the room. Perfect, okay. So we're going to make sure that you talk into the microphone because all of these sessions are being recorded. They're available online. And if you don't talk into the microphone, then nobody will know what question you asked and nobody will hear your fabulous voice. So the reason I said that this topic is close to my heart is that I get to serve as the CEO of an organization in Montreal that has a variety of partnerships with the healthcare network. We have a partnership in dentistry with the McGill Faculty of Dental Medicine and Oral Health Sciences. We have a partnership in mental health with the Jewish General Hospital in Montreal and the McGill Department of Psychiatry. So this is a topic that means something to me personally because I know it works. When you bring healthcare and the need to serve vulnerable people together into a space where they can be served effectively, good things happen. So you're going to hear more about that. Without further ado, I'm going to call on our first set of presenters. So come on up, introduce yourselves, tell us who you are, and take it away. And let's welcome them.
Thank you, everyone. So today we're here for the presentation, Bridging Shelter and Medical Services, Practical Learnings of Adopting an Innovative Model. My name is Michael Potvin. I'm the Director of Client Services. I'm going to turn it over and we're going to introduce ourselves and we'll go from there.
Good morning, everyone. My name is this on? Yeah. My name is Lacey. I'm the Assistant Director of Client Services.
Good morning, everyone. My name is Baeta, and I'm the Manager of Research and Data Analysis at Homes First in the Client Services Department.
Hi, everyone. I'm Wolfson-Stofko. I'm the Manager of Harm Reduction and Health Services at Homes First.
All right, so this is a little bit of an outline that we're going to go through today. Just before we get started, though, I wanted to ask, can I get everybody in this room who is a shelter provider to raise your hands? All right. Can I get now everybody who is a medical provider, so working at a hospital, a CMHC? All right, us shelter providers are a bit outnumbered. All right.
So before we get started, we're just going to do a quick overview of Homes First. So Homes First is a nonprofit agency in the City of Toronto, originally founded in 1983 by a group of different organizations that were working with different individuals across the City of Toronto that were experiencing homelessness. Our mission statement and the clients that we work with are those that have complex needs and that are typically the hardest to house. So as part of these housing solutions, we operate several emergency shelters and also different housing sites throughout the city. So supportive housing, both low and high needs supportive housing. So like I said, we do have emergency shelters, so I do ignore the numbering there. We operate 9 emergency shelters, not 12. Those range from hotel shelters that were opened during the pandemic to congregate shelters, ranging from shelters of 20 clients up to around 400. With those 9 shelters, we currently operate 1,759 shelter beds in the City of Toronto, which is approximately 25% of the shelter beds in the city, so it's quite significant. Along with emergency shelter sites, we do also operate 15 supportive housing sites. two of which are high-need supportive housing sites that have staff on site 24/7 for those with more mental health and addictions needs that need staff on site 24/7.
So during daily operations in our shelters, we noticed that our clients and our frontline were having a few challenges. Some things we noticed were a lack of communication with healthcare providers. Clients were being discharged from hospitals to our shelters too early to kind of operate in our shelters independently. Clients having to go through complex referral processes that were sometimes inaccessible. Clients were experiencing discrimination sometimes when they were trying to access healthcare. There was a poor continuity of care and lack of patient-centered care when clients were discharged, and difficulty accessing PSW supports for our clients, and clients' supports based on their self-identified gender. So with this in mind, we kind of launched an evaluation to inform our strategies moving forward. So our main goals of the evaluation was essentially to identify gaps in healthcare services offered in the shelter system, best practices to address these gaps, and explore supporting staffs and clients and how we could kind of benefit, we could adapt strategies and supports to benefit everyone involved. So in doing this, we conducted 5 focus groups. The focus groups had the same questions throughout all of them. They were approximately 45 minutes each, and we also did a literature review. So the focus groups were held with case management supervisors, shelter site managers, shelter supervisors, our current health navigation supervisors, medical doctors that worked in the homeless sector, and nurses that worked in the homeless sector as well. So after concluding our evaluation, we identified that our health navigation supervisors at the sites that we had them operating at were providing efficiency. They allowed our healthcare partners to effectively support our clients. They increased access for our clients to the partners that were coming on site, and they provided navigation. So they supported our clients in kind of navigating a fragmented healthcare system. And then we also identified a few gaps in the evaluation as well. So we noticed a gap in terms of diffusion of responsibility. So shelter positions would assume that it was the responsibility of our partners and health navigation supervisors to provide all health supports in the shelters and all referrals. And we noticed scope creep. So a lot of the sites where our health navigation supervisors were active, they would take on roles kind of beyond, and tasks kind of beyond their capabilities. So they were kind of responsible for all the health needs of everybody that was at the shelter site. So in our findings, we had a few recommendations. So one of the recommendations we had was consultation. So for our health navigation supervisors, they should be kind of providing a consultation role to frontline staff. So they would keep up to date with what was happening in the shelter and update trainings and consultations depending on the trends at that current time. We recommended to build frontline capacity. So this is kind of in continuation of consultation and just making sure that everybody at shelter level and frontline knew what they could do and knew what could be done, even if a health navigation supervisor wasn't on site all the time. And we also recommended that the health navigation supervisors kind of oversee health partnerships and not necessarily the immediate day-to-day operations of our partners when they did come on site.
All right, so some of the objectives of this model that we had were to try, of course, improve the communication and coordination between the healthcare providers and the shelters, which we identified was a gap, increase likelihood for clients to attend their appointments, access the medical care, and follow their treatment plans. Want to create and maintain strong working relationships with all the healthcare partners that provide on-site care. We have a number of those. And identify as well unmet needs and physical health needs that we can get partners who can then support with fulfilling those, as well as build skills and capacity of the staff to support with client health, in addition just to the housing and social supports typically provided in shelters. So how we're operating this right now is we have four health navigation supervisors that oversee a variety of sites, and they collaborate, as we mentioned before, with all of our frontline staff, frontline operations team, all of our case management team, as well as our harm reduction supervisors, because harm reduction is health and health is harm reduction. And so there's a lot of collaboration there. And the health navigation supervisors also oversee some health liaison staff that we have that assist with some very basic supports, so our supervisors don't get bogged down. As I said, there's assigned a portfolio of typically shelters and high-need housing sites. We try to have them present at least once a week at each of these sites to provide support and get insight and see what's needed. And from how it kind of breaks down here, it's not just need, but also size of some of the sites. Like we have some that are about 18 people, specifically our LGBTQ plus shelter for refugees. Meanwhile, then we have some other large refugee programs of about 400 people at the site. And so we weigh it out to try to make sure that we're able to take care of everyone there. And then, of course, the high-need supportive housing sites, though not as large as some of our others, require a lot of effort, as you might imagine. So for some of the resources here, we try to have the health navigation supervisors delegate a lot of tasks to some of our frontline staff, just so that and case managers, so that they can focus on more high-level needs. And we want to empower them to problem solve as well, to access resources, get more staffing supports, and also be in communication with our health partners to make sure everything goes smoothly and folks get what they need. And also, they are empowered to advocate for our clients with the hospitals and other external healthcare providers. As we mentioned, sometimes we understand the crunch in hospitals, and they're sometimes very quick to try to push folks out to open up beds. But what's happening is we did not have the supports in place, or were able to even provide some of the supports in the shelters, or the environment just was not appropriate for the type of supports that the person needed. And so we also are trying to get everyone to share resources as well as and work as part of a team is really ideal. And when, we have all different departments, so the health navigation supervisors are part of our client services department. And so we collaborate and work with the operations team, property team as well as needed to ensure that we can really support the clients and get them the resources that they need. And so some of the main things that they are responsible for is they're essentially the key point person for coordinating all of our partnerships, health service ones in particular, for both on and off-site care delivery, because there's a variety of, we only have so many resources on site. We do bring physicians and nurses on site, but they have limited capacity. And so then for folks that are more low needs and capable of seeking services in the community, we encourage that and try to connect them, get them directions, et cetera. They're also going to look to identify health trends and needs that we can improve upon and help improve client health. For instance, it was mentioned that a lot of our LGBTQ refugees were not having access to hormone therapy, and so we were looking into that and been successful in trying to get them access. Again, as I mentioned, working with the hospitals to support any kind of discharge back to shelter. There was a case recently, and this is relatively minor, but just things that always need to be considered, where we had a client that had pretty severe sleep apnea and needed to use a sleep apnea machine that had to plug into the wall, and there was no outlets around their bed or anything. And so they come back, they're not using it, and we're concerned, and it's okay, so now we got to move stuff around. That was a relatively minor thing with an outlet plug that we could address, but they've had other issues where a client had brain surgery and was trying to recover in an open dorm shelter and just really didn't quite have the resources. So we tried to then move him to another site where he would be a little bit better supported. So we also always have them monitor all the shift reports to see who's accessing emergency services, so we can follow up with the hospitals or other healthcare providers And then, as I said before, delegate frontline staff and case managers to support as needed. And also build frontline staff and case manager knowledge capacity around some of the common health conditions and treatments, as well as some that are not as common. But like, for instance, with like dissociative identity disorder, and just like letting our staff know on how to engage with clients that have this condition by like asking like, who am I talking to right now? Because you're not quite sure, and you have to speak to different personalities in a different way. And so it can really kind of escalate someone if it's not done appropriately. So we'd really try to educate folks the best we can. We're also in the process of getting all of our health navigation supervisors trained in first aid and CPR so that we can train all of our staff in that in-house. And this was also due to identifying that some of the CPR first aid trainings that were being done externally were not quite meeting our needs, in that particularly we see a lot of overdoses in the shelters, and it was very much glossed over and not really being described to our people as best practice of how to respond to an overdose. And so, instead of giving the lock zone, a lot of the first aid instructors were telling just to go straight to chest compressions, and we're like, they have a pulse. That's not what we need. They need some naloxone, and then we can kind of go from there. So we're doing this in-house, and we're hoping to really everyone to be certified by early next year.
Just before I start my slides, I'll also say for first aid in-house, due to scale, it's also much cheaper for us as well. Some of the rationale behind why we've set this model up, not even just in addition to the evaluation we did, the literature we reviewed as well, but we really saw some of the importance of having an embedded program within the shelters. A lot of different funder conversations I've had, different committees I've been on, a lot of the focus has been placed on having workers that support clients in the shelter system actually operate out of the hospitals. And from our experience with that, the lens coming from that perspective doesn't understand what's actually going on within the shelters. They take a lens of what's going on in the hospitals, how the shelters need to change without actually knowing the context of the shelters. And we really saw the importance of having a worker in the shelter to advocate from a shelter's perspective and lens what the client would need coming to that environment so that they were able to be successful, have that continuity of care, and ensure those supports come into the shelter when they're being discharged from hospitals or even just getting prescriptions as well. We also saw the importance of the role needing to be a supervisor role. So we've experienced this and had several observations where there were specialized roles like a harm reduction frontline worker. But when they tried to collaborate with other positions were like, well, you're a peer. It created a lot of challenges in working together. But having somebody who's an actual supervisor who has, for lack of better terms, the authority to make sure that resources are utilized and when tasks are delegated, they're actually being done. Having that position is really important as well. It also gives the position in this model more leeway to have conversations with hospitals and healthcare providers to say, this will not work. And I'm telling you this as a supervisor, as the shelter. As well. It also gives the position the ability to do more relationship building and maintenance. And I've heard this in a couple committees I've been on and through different discussions as well, where a healthcare provider would come on site and the shelter provider would say, well, we can't really tell our staff to listen to all the tasks that are being delegated by the healthcare provider because they're not their supervisor. There's a union here. How do you actually navigate those waters? Well, with the position being a supervisor in this model, we say maintain the working relationship. So it's not necessarily they're going to do all the tasks that the healthcare provider is going to do. In fact, we wouldn't want that. We would like it to be a discussion back and forth. But if we say maintain the working relationship with them, and if there's larger issues coming up, obviously come to your leadership and we'll figure out a solution collaboratively together, we're able to maintain those working relationships much better. And then we also established agreements between the different departments, which is so important. So we have a housing department, we have a shelter department, we have a property department. There's a lot of different players going on, not even just between the shelters, but within the shelter system as well. And actually coming together and saying, well, this is what the model looks like. If we are delegating tasks to different positions, what does that look like? What is their follow-up, those types of things, and having that pre-established agreement ahead of time was really important. So in implementing this model, and all implementation is messy, I've learned that through many years, but some of the key findings we found were the importance of communication. So communicating what the model looked like, talking about why we wanted to implement the model, even looking at some of the internal data with our other departments to say, well, this is what we want to do, this is how it will impact you, and this is also how it will benefit you as well. Something we found, and I'll talk about this a little bit more, is sometimes clients we would see on reports, they would go to the hospital, and there was no follow-up. We didn't know where they went. We didn't know if they were coming back. And then one day they would just show up at our doors with no communication and our shelter's full. And it's like, well, now we have to support you to go back either to the hospital or try and find you another shelter bed. And we know in the city of Toronto, trying to find another shelter bed can take days. And if you don't have access to a shelter bed right there and somebody just came out of surgery or needs specialized supports, that makes things very difficult. So everybody on the senior leadership team saw the value in this. We were able to communicate that, but we were also able to discuss and get feedback some of the challenges and concerns as well. So one of the key challenges was at some of our big sites, it was easy to have frontline staff support this type of model. However, at some of our small sites where there's only 2 staff on shift, it can be a lot more difficult to delegate tasks and have those things carried out as well. So we negotiated what would that actually look like, and being able to provide that context as well. And then after we did implementation, we also did check-ins as well to make sure it was working, and we adjusted course when it wasn't working. So everybody always cares about outcomes. I can tell you about this fancy model, but if there's no decent outcomes, well, who cares? So something that we have seen initially is that across our shelter systems, we've seen a lot more connections with hospitals. So this doesn't mean formal connections where we've signed up partnerships, but what we're really getting at is our health navigation supervisors have actually created good points of contact with specific workers in hospitals. So we're in a region, we know one of our clients has been taken by EMS to the hospital. It happened at 3 a.m. in the morning, so we're not really sure which hospital they've gone to, but we have consent with the hospitals for that client. Well, our supervisor is able to pick up the phone and call Sally at Hospital A or Hospital B. Then we can actually start tracking down that client and supporting that client to eventually transition back to the shelter, or make sure that if they did get referred medication, that we're able to make sure the client gets that medication. We can give reminders in the shelter system to take the medication and follow the actual plan so the client actually recovers. So you can see at some of our shelters, we had almost no connections, and with creating this model, it's significantly increased. You can also see here as well unique individuals that are frequent flyers of the hospitals in the last few months, how many times those clients have been connected with, but those connections have happened between the hospitals. And I do really want to point out these are unique individuals, and some of them have been to the hospital several times as well. Another main goal of this model as well was to create equitable supports across our shelters as well. So sometimes clients would go to shelter A and they would have more resources, more partners there. However, if they went to shelter B, they didn't have those partnerships set up. And when it came to their healthcare needs, we saw there were it was unequitable. So by creating this model and all the health navigation supervisors being on one team, people share these resources together, and we look at expanding our partnerships that were existing at maybe Shelter A to also Shelter B as well. And we've seen a large increase in the last few months of 9 partnerships being expanded across more of our shelters as well. We've also been able to identify new partnerships that are needed as well, and we're in the process of setting them up. So for example, one thing I really like about this, and I'm kind of talking about it even though it's on my next slide, is that by having a health navigation supervisor embedded within our shelter system, it gives us a lens to look at from what are the actual health needs in those shelters. We have so many demands going on within the shelter system that if you don't have a position that actually focuses on that, that's able to actually communicate what those needs are, it gets overlooked because you have 100 other things on your plate as well. One thing I really like to bring up that I thought was a really cool outcome, and we'd like to explore it a bit more, was at one of our shelters that serves people who are LGBTQ+, we're finding out that we actually need, well, it's obvious, but this gave us the lens to think about it, but access to hormone therapy for clients within the shelter system as well. So it's not about always equitable supports across all the shelters or equal supports across all the shelters, but there could be specific populations that need specialized types of supports in certain shelters as well. And this gives us a lens to actually look and support clients there. So what are some of the other benefits that could be quantifiable, but we just haven't gotten around to quantifying it, or may not ever? So one thing I really like about this model is instead of individualistic workers, I see it as creating a safety net under our shelters that we track and identify clients engaging with the healthcare sector so that we have somebody follow up and make sure that the supports that are being put in place by the healthcare sector are implemented within the shelters and also make sense from a shelter provider perspective as well. So clients don't disappear. We're able to support them and able them to get them the help that they need as well. It helps give us a focus on health supports within our shelter system, which is much needed. Obviously, we focus on things like harm reduction as well, which is part of health, like Brett said, and housing first, and all of these types of elements, and they definitely intermesh. But by having this position and model specifically, it keeps somebody emailing me, phoning me once in a while and saying, hey, Michael, we need these kind of additional supports here. And that puts it front of mind, which then causes me to spend energy and results in clients getting better supports as a result. It helps us build more knowledge and skills for our frontline staff as well. So we talked a little bit about that consultation role. So that consultation role that the supervisors take on, and that's why the position has to be a supervisor as well in this model, is that it helps build training, but also allows consultation for specific client cases. So obviously we're not saying like, oh, this person needs surgery, but we're saying, okay, well, these are the challenges. This is the type of referral we would make to get the client the supports that they need. So it builds capacity in our frontline staff who then share that knowledge amongst themselves. But our frontline staff always have a supervisor that they can go to who specialize in knowing what kind of resources are out there for health supports. It also helps create increased access to standardization across our shelters for health as well, and more equitable services. And that's it. Thank you.
Good morning, everyone. So, hi, I'm Stephen Hwang, and with my colleagues April Alleman and Alex McKinnon, we're going to be talking about implementing and expanding a hospital community navigator program for patients experiencing homelessness in 3 settings. Just to tell you a little bit about the organizations that we're with. So April and I are with St. Michael's Hospital, which is an academic teaching hospital in Toronto. I'm also the director of MAP, Center for Urban Health Solutions, which is a health equity research center at St. Michael's Hospital. Alex is with St. Paul's Hospital, which is part of Providence Healthcare in Vancouver, British Columbia. So it goes without saying that there's a high need, that people experiencing homelessness have high needs for health care. We actually know from research that our center has done that the average person experiencing homelessness is admitted to hospital about 4 times more often than someone of their same age and gender in the general population, and that their health care costs are about 6 times higher than that of someone in the general population. And so looking at this from the hospital perspective, at St. Michael's Hospital, which is located in downtown Toronto, we see this in the number of people experiencing homelessness that come to our doors every year. So there are more than 9,000 emergency department visits by people experiencing homelessness to our emergency department every year, representing more than 3,000 unique individuals. So this is obviously a really large number and kind of an overwhelming problem to try to focus on. So what we have done with this program is focused on the subset of those people who are so ill that they require admission to the hospital. And as you can see from the slide, every year at St. Michael's Hospital, more than 500 people experiencing homelessness are admitted to the hospital. So these individuals are the focus of our Navigator program. So I'm going to just use this cartoon to demonstrate the problem, and just to say that because I'm a physician in general internal medicine, taking care of patients admitted to the hospital, as well as working in shelter settings, taking care of patients in the outpatient setting, I see this from both sides. So what happens is that people are admitted to the hospital. We spend days, weeks, sometimes months getting them better, and then we discharge them. And as you can see here, there's a discharge plan, and for anyone who's ever had a friend or family member or yourself been in the hospital, you get a discharge paper which says something like, "Dear patient, please follow these instructions." And I think what we all realize is that what then follows for our patients experiencing homelessness is a list of instructions, almost all of which are either extremely difficult or impossible for them to carry out, and many of which are going to just not happen at all. And what happens as a result is that often the person goes out into the community, and as we've heard in the last presentation, their needs are not met, and often they end up right back in the hospital. And research that we've done has shown that the readmission rate for people who are experiencing homelessness is about 30% within 90 days, which is much higher than that of the average person being discharged from the hospital. So what we did is we created what we call the Navigator program. And there are many different kinds of navigation. So when I talk about the Navigator program, I'm talking about one that's specifically tailored for patients experiencing homelessness who've been admitted to the hospital. So our Navigator program has 4 key features that are really important to understand, because I think that they're all critical to this effectiveness of the program. So the first is that the Navigators are members of the hospital care team, and they build relationships with clients from the first day in the hospital. So in other words, they actually have hospital status, and there's no question when they walk in the door of the hospital, like, who are you? Are you part of the care circle, and why are you here? They're part of the hospital staff. So they're integrated in the hospital. And as I mentioned, on the first or second day the person's in the hospital, they can come into the patient's room and say, "Hi, I'm here to help people who are unhoused. Is there something I can do to help you?" And they get to know them and start building that relationship. The second key aspect is that navigators are highly skilled case managers who have homelessness-specific expertise and extensive community connections. So for those of you in the audience who are actually from the shelter and homelessness service world, you already know these people, but you also, I think, understand that those people are far and few between, and in fact, usually non-existent in the hospital world. So what we've done with this role is we've created a hospital-based role, but for someone who has this expertise and connections in the community. The third key aspect of the program is that navigators follow patients in the community after discharge and connect them to the services they need to make the discharge plan real. So the key thing here is that the navigators spend half their time in the hospital getting to know patients while they're admitted, and half their time in the community connecting with patients who have been discharged and making sure that they get to their primary care appointments, that they have a primary care doctor, that they have a place to go to when they're discharged, that they have transportation to get to an appointment, et cetera. And lastly, the program includes a flex fund to support client needs. So there is a fund that the navigators can use to to intervene in ways that can make a huge difference. And so we call it a flex fund because it's not limited in what we can do with it. But just to give you examples, key examples of how we use the flex fund, one is we give people cell phones. And the problem of like, well, they were discharged and now we have no discharge plan because we can't contact them, at least we can contact the patient and help arrange follow-up and help them meet their needs. And we can also, another thing that the Flex Fund does is, as I mentioned, help people provide them with transportation to appointments and other critical things that they need to get to. So I'm just going to give you a bit of a chronology of how the Navigator program has been developed and rolled out. So we started the program, we developed the concept in 2018 and then initiated it in 2019 at St. Michael's Hospital in Toronto with hiring one full-time navigator. In 2020, we were able to increase the program to 2 full-time positions. In 2021, we were able to start a research study to evaluate the effectiveness of the Navigator program. I should mention that it was planned from the very beginning of the program to evaluate it using a randomized controlled design. So essentially what we do now at St. Michael's Hospital is we approach people who are homeless, ask them if they're willing to participate in a research study, and if they are randomized to either receive the Navigator services or usual care, and we're tracking people for 3 months afterwards to determine the effectiveness of the intervention. We expanded the program to include St. Joseph's Health Centre, which is a community hospital in Toronto, which is part of the same network, healthcare network as St. Michael's Hospital. We'll hear more about that. That expansion lasted for about a year. In 2023, we expanded the Navigator role to 3 full-time positions, and even with 3 full-time positions, we are only able to serve about half of the people admitted to the hospital experiencing homelessness. In 2023, the Navigator program was launched at St. Paul's Hospital in Vancouver with 1 full-time position, and you'll hear from Alex about that. And in 2024, the program at St. Michael's Hospital was expanded to include patients, clinic patients, not admitted patients on the general internal medicine, in the general internal medicine clinic. So now we're here in 2024, and since the start of the program in Toronto, we've served 900 people. The results of the research study are anticipated next year in 2025, and we're currently working on sustainability and scale up, and that's why we're so happy to be talking with you here today. So at this point, I'm going to turn it over to my colleague April to tell you more.
Hi, everyone. I think our presentation fits really well with the presentation that went beforehand. So I'll talk a little bit about the implementation of the program at St. Michael's. So a lot of this is just focusing on the evaluation that was done by our colleague, Dr. Jessie Jenkinson. She presented some of this last year. So a large benefit of the program is actually us being embedded in the hospital, like Stephen was saying. There's no question about who we are, what are we doing there. And because we're able to communicate with the team, with the doctors, the residents, the nurses, social workers, it really does make a big difference. I can see, I've worked in community, and trying to get a hold of someone in the hospital to see what's going on with a patient is almost nearly impossible. Everyone is so busy. You get transferred from floor to floor. You have no idea what's going on. So I can empathize with what the shelters are going through because I've been in that position. So we also act as a liaison, right, between us here in the hospital and people who are staying at the shelter. We can connect with them, let them know what's going on, and take a little bit of that load off from the social workers, discharge planners, or people in those roles. And I think this also gives us a unique opportunity to also provide some education to staff. I've had countless conversations with nurses, with all kinds of staff who are just unaware of what's going on, especially in Toronto. Shelters are all at capacity. They have no idea what a shelter looks like, what a shelter is like inside, what are the supports available. They're shocked that someone can't get a shelter bed and has to be discharged to the street, right? So I think that education is also super valuable that we're able to provide to our staff, to our colleagues, and also provide resources, right? People feel really comfortable now approaching us, asking us questions about resources, asking us, all these kinds of things that they're unaware of. And I think because we're all colleagues and work together, that having that conversation makes it, it's a lot easier. So like Stephen was saying, we have that community experience. We've all worked in community. We know what it's like on the other side. So to give like a brief example, we have lots of patients who come in with jaw fractures. Their jaws are wired shut, and they say, okay, yeah, like they can be discharged. They just have to be on like a pureed diet. It's like, okay, did you know that a shelter can't actually do that? Do they have a blender? Are they actually able to accommodate this request, right? So what's something else that we can do? Do they need to stay in hospital? Do they need to go to like a respite after hospital? It's just those little things that, you usually don't think of, and we're able to kind of provide another lens to the staff in the hospital, and it's super valuable. And then we also, because working in a hospital, we end up having a little bit of that medical knowledge. Not that we're, doctors or anything, but patients often have no idea what is going on with their health. Residents are coming in and out, doctors are coming in and out, nurses, all these people, they don't know what is going on. They're using all this medical jargon. So sometimes we're able to provide a little bit of, that humanity of like what is actually going on with their health. If they don't understand, I can go look for the resident, the nurse, and say like, hey, this person's having questions about, why is this test being done, or what is being done? What's the medication they're being given? And that is also such a helpful role that we play, I think, as well with the people we're working with. Another benefit of the implementation here was Stephen. Like, he's worked at St. Mike's for, I don't even know how long, a very long time. Very well known in the internal medicine floor and across the hospital. So him starting this program, starting this research, everyone was quite receptive to it. I imagine I wasn't there when it started, but everyone recognized the need, and we're very welcoming of the program. So that's a big help in ensuring the program's success. And yeah, so we started with one person, and when, Alex maybe can speak to this a little bit, but when it's one person, is it really a program, or is it just one person doing the role? Having one person fully committed to the role is definitely a help. Having someone do it part-time or adding it on to, a social worker's role is not very helpful. It doesn't serve the need of, the patients that we're working with. And now that we've grown to 3 people, it really is a program now, right? Everyone knows us. We know the services that we provide. They know how to refer to us. And we're able to build those relationships with the community partners as well. We know who to contact at the shelters. They know to contact us if they have questions, if someone's being admitted, so that those partnerships that we're establishing as well are super important. And those obviously take time and consistency, and the fact that we're able to keep, the same staff over time as well definitely helps in building the relationships with the patients as well. When they're admitted, they see us, maybe we lost touch, they come back, they can remember us. You got me a coffee that time, you got me a donut, whatever it is, right? So the consistency plays a big role as well. And I think an important thing to note as well is because we're based in the hospital, we do represent a medical healthcare institution. And St. Michael's is a Catholic institution as well. So I think we play a very unique role in being in community and being in hospital. And, to a lot of people, we can represent all of the trauma and racism and everything that they endure being in a healthcare setting. And hopefully, we're helping a little bit to undo some of that harm that's been done and trying to repair those relationships as well. So as Stephen mentioned, the Navigator program was expanded to St. Joseph's Healthcare Center in Toronto. It's just about 6 kilometers west, I looked it up, of Toronto, so out of the downtown core. And while 6 kilometers is probably not that big of a distance, taking transit there is probably an hour to an hour and a half. Driving even in traffic, like during a workday, is probably 45 minutes. I had to go to an appointment with someone. I gave myself an hour and a half to get there by transit. I was only like 5 minutes early. So I think that spoke to a lot of the challenges. We didn't have one person there that was at St. Joe's full-time, committed every day. So for someone to go back and forth, that's already a lot out of the day. And we end up missing people who are referred on the days that we're not there. So I think that goes against one of the core components of the program, which is to have a full-time person committed in the space. We also didn't have an actual physical space for someone to be in the hospital. There was nowhere for them, even to just sit at a desk. So that makes it really hard to connect with the team. And like I mentioned earlier, Stephen, well known at St. Mike's, there was no one at St. Joe's that was kind of like the champion of the program. No one really knew about the program, how the referrals worked, getting referrals that were maybe not as appropriate because people didn't know about them, weren't as familiar with the program. And because, again, we weren't able to commit someone there full time, building those relationships in community with community partners and such was really difficult when you're maybe there 2-3 times a week. So I think a lot of those challenges that we experienced at St. Joe's are helping us to learn what we can do better next time, help to learn a lot about implementing the program at St. Paul's in Vancouver, and also just, really spoke to the core components of the program and really validated that what we're doing at St. Mike's is probably working a little bit better than what we were trying to do at St. Joe's. And then the last kind of iteration of the program is at the General Internal Medicine Outpatient Clinic at St. Mike's. So essentially people visit the ED, they're maybe not sick enough to get admitted into hospital, but should probably be seen sometime soon by a doctor for some sort of follow-up. So because of the staff physicians that work in the hospital, they also were working in this clinic. They saw a need and approached us to try to, expand the program to that clinic. So the funding for the third Navigator was tied to this agreement to support patients who were at this outpatient clinic. So we met with the clinic director, administrative staff to try to determine, eligibility and the process. So a lot of people in hospitals are just NFA. That might not be accurate. An address, they could have an address on file, but they actually are experiencing homelessness. It could be a shelter address. Staff don't know that it's a shelter. So we're trying to figure out those little intricacies as well. And then just setting expectations as well. We work in community, like Stephen was saying. So, if they call us and say, hey, a patient's here, we may not always be able to respond as quickly as we can. They do try to let us know when an appointment has been scheduled. Usually people visit the ED and then get an appointment the next day or the day after. This part is still pretty early in implementation, around 6 months, and we're working with around 7, all three of us are working with around 7 clinic clients, and we've been hovering around that number since it started. And then I think something to note in doing it in an outpatient setting is that the rapport and relationship building is much harder to do in one appointment. When someone's admitted to the hospital, we see them, we can, get them. Some people request magazines, arts and crafts to try to pass the time. We can get some food. We sit there with them, get to know them. We're so lucky to have that time to build that relationship and that rapport. When we visit someone in the outpatient clinic, they're there for one appointment. They've maybe already talked to 2-3 healthcare professionals and are just overloaded with information. So it's a bit of a challenge to try to figure out how to get that buy-in from someone and how to really establish that relationship and try to keep working with them. And we're also tracking the data and all the information from this outpatient clinic separately. So we'll want to see if there's any differences in the outcomes as well between these 2 different iterations. And I will pass it off to Alex.
Hi there. My name's Alex. I'm the outreach navigator at St. Paul's Hospital in Vancouver, which is located on unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. As they were saying, the goal was to expand the program out. And before me, the folks at the Toronto Navigator program learned from their experiences, like April was saying, through the St. Joe's experience. And so they did a bit of the back end of the work first with St. Paul's. They reached out. They had many, many meetings with leadership, clinical, administrative. As you know, like every hospital's different, so there were different things they had to process. They really emphasized to the St. Paul's leadership the importance of having the staff hired through the hospital and based on site, just for the reasons that April was talking about there. And stressed that the need for supervision and support for the outreach staff, even if there was only one person in the position. And I'm thankful for that you emphasized that. So they took the time to learn about the differences of the hospital structures and listened where to adapt and where things needed to change. So because of St. Paul's structure, they needed to hire the navigator as a social worker, which is not the same as the original program. The original program, the navigators have different backgrounds. So this would guarantee support and supervision through how St. Paul's structured. And they hired me into the role. So the original St. Mike's navigator, as April was saying, is, has a community background. I have an inpatient social work background, so it is a bit different. There were pros and cons to that, obviously. I had to come and learn more about the community side. It was still the same population I was working with, but there's just a lot of intricacies, obviously, with community resources. The plus side of being already an inpatient social work is I had some of those established relationships with the doctors. When I started chasing them down for things, they already knew who I was. So that was good. And then just, we talked about the implementing kind of the administrative side, but me personally, I noticed some strengths and challenges in starting this program in Vancouver and also being, one person. So I think the strengths of the program in St. Paul's part was that, it's a pretty supportive organization, their culture. So they have a very robust social work department, Indigenous wellness liaison department, inhalation tent on site, safe injection site. So they were very welcoming to this position. But I would say for the sake of implementation, if you are in a hospital that you're thinking is not going to be as welcoming to this, I think it goes back to what Stephen said about you can spend days and weeks making these discharge plans, the patients are invested, but then at the end of the day, right, things can get lost in translation. These systems are super complex, so why not go that extra step and have someone helping carry out these plans? And yeah, for that, I think it can make a significant difference in bridging the gap between just planning and real life outcomes. Being based on site and having access to the medical charts, again, when I need to chase down physicians for something I don't understand in the discharge plans, or this isn't realistic, or where did that script go? Being on site is really important, meeting patients where they're at, being able to run down to the ER when I know one of my patients has come back in is super important. And community of practice, I came into it, I was one navigator. I knew the hospital, but I was learning community and what this was going to look like. So really just, I think the crew at St. Mike's wanted to have that, they were always available, Zoom, a lot of support, supervision, questions, right? They were always around for that. And of course, I think in your presentation, you're saying implementation can be messy, right? So there's obviously challenges, or just things that I started to think about a bit more. Hospitals, obviously there's staff shortages.
and I was an inpatient social worker, so I was, there was some unit coverage creep. I don't know if I just made that word up, but I was getting pulled to a lot of other things. You can get pulled into things, so I would just caution if you're hiring someone who's already in the hospital, they might, it's tempting to pull them to cover ICU, or it's tempting to pull them to cover other things. But I think this stopped happening when, leadership saw that what I was doing outside of the building was still directly connected to the hospital and helping patients thrive. So I've been not covering the units now. Increasing awareness to avoid duplicating services. So there are so many amazing, well-established outreach teams in Vancouver. And just to make sure that we aren't duplicating services, we did an introduction to community when this program first started. And I'm still learning about the organizations, working with them, and always just making sure the patient's expertise of the environment and the other organizations, the well-established outreach teams, I'm kind of taking their lead. And then, as April said too, one thing is trust within the community, right? I recognize the healthcare system has caused and continues to cause a lot of damage with marginalized folks and unhoused folks, and especially Indigenous populations. So just being aware of that and making sure that I'm there for the patient, their discharge plans are really their choices inform what we're going to do next. We're looking at the discharge plan that we got from the hospital, but it's up to us to kind of figure out what to do with that. And when a patient, texts me something where's the script? Where's my next appointment? I see that as a nice link to the hospital, right? Even if it's just a little reach out. And trust within community, that goes for shelters too, right? I remember when I first came to a shelter and I was saying I'm from St. Paul's, and I got a bit of because we've done harm, right? Just by sending people who aren't maybe medically ready or not reaching out first and seeing what those resources are like. So just making sure I'm building those trusting relationships and like April said, informing people in the hospital kind of what's going on in community as well. So yeah.
So I'm going to wrap up. I'm not going to address these questions. I'm just going to point them out that they're key things that perhaps we can talk about in a Q&A or with you afterwards. So just in implementing this, do we understand the context that we're working in and what it would mean for a program like this? Does the program or innovation have support? And if not, can we build it? How can we share our learnings in an ongoing way? And certainly this is part of that discussion. And we haven't talked about it much, but what data should we collect and how can we use it in order to build the case for programs, this program and programs like it? So just if you have any questions, this is the website that describes the program, and this is my email and the email of Kate Francombe Pridham, who is the manager who works with me on this program at St. Mike's. So feel free to email us if you have any questions. Thank you very much.
Hello again. So we are doing a presentation on a collaboration. The title of the presentation is called Creating Homeless Hospice Through Strong Partnerships. And my name again, if anyone forgot, is Michael Potvin. I'm the Director of Client Services.
Hi everyone, thanks for being here. My name is Felicia Cantopidis. I'm the Director of Care at Journey Home Hospice. I've just completed my master's in nursing and my nurse practitioner in primary health care.
Matthew Durham. I serve as the Executive Director of Hospice Palliative Care for SE Health or St. Elizabeth Healthcare.
This is just an outline of what we're going to be covering today. And for the sake of time, not because I'm lazy, but for the sake of time, Lacey already covered these, so I won't go over them again. This is just a bit of a history of Homes First and the different sites we cover.
So just to give you a little sense of our organization, so again, Felicia and I represent SE Health, or St. Elizabeth Healthcare. We've been around for about 115 years in Canada, actually 115 this year, providing mostly nursing, personal support, OT, et cetera, in home care. And so we're 9,000 employees across Canada in most provinces, serving over 25,000 home visits a day. And so the SE Health, as the social enterprise, is Canada's largest health enterprise, and we call it the business of caring. And the business of caring produces the funds that then support St. Elizabeth Foundation. And our focus for the last little while at St. Elizabeth Foundation has been end-of-life care for those most in need. And so who are those folks most in need? Currently in society, of course, homeless and structurally vulnerable individuals. So our focus has been on that. We do have other programs I have listed, but again, for the sense of time, I won't go over it, but please feel free to look at these handouts later to get a fuller understanding of the programs that we offer with our foundation. So together, we, with the vision of, I don't know if Patricia Mueller is here, but Patricia Mueller is the CEO of Homes First, and our Chief Operating Officer, Nancy Lefebvre, that they had this vision, and they were discussing, it's one thing for St. Elizabeth, who's provide home care at end of life for 115 years, but what about those folks who don't have a home? And so they started having a chat what this might look like. And so in 2018, together with Homes First Society and St. Elizabeth, we opened a 4-bed pilot, hospice pilot at Shooter and Jarvis in the downtown core. So we're just a few blocks down from St. Mike's. And so like a traditional hospice setting, we have 24-hour hospice care with wraparound services, psychosocial support, spiritual care, obviously nursing, 24/7 PSW, physicians, and now a NP-led program under Felicia's direction. And so we started, but we wanted to do this right. And so we said, let's not rush in. We were approved for 10 beds, funded in Ontario for a 10-bed model. But we said, let's not rush into this. Let's do this right. We only have one chance to do this right with individuals, because at end of life, you don't get to do it over, as we all know. And so we started with 4 beds. And we knew we were going to learn a lot from the patients every day. And we continue to learn a lot from our patients. So that was in 2018. In 2020, during COVID, we did a renovation on the site at Homes First, and we went to a 10-bed model. And then again, we saw a need in 2021. Felicia continued to see our patient population coming in appropriate at a palliative performance scale. Their needs were being met. But after a few good weeks of good pain symptom management, access to 3 squares a day, and all our complementary therapies such as music and art therapy and spiritual care and psychosocial support, they kind of got on with their living, which is what hospice is all about. That's what the model is all about. And so we didn't want to start discharging back onto the street or into the shelter system where the decline would happen again. And so we created another level of care. So we have a 3-bed pilot at Homes First, once again, that provides what we're calling chronic hospice palliative care. And so Felicia is able to discharge into our own program. They get on with their living. They still have access to all those things I just talked about, but they come and go as they please. They can go visit their street family, their networks, etc. But as they decline, we can admit back into the hospice proper for their end-of-life care. Felicia's going to speak better than I'm not a clinician, to what makes this a specialized. So everything I talked about before is sort of what's offered in a traditional hospice setting, but what makes Journey Home Hospice a specialized hospice? And that, of course, is our trauma-informed, culturally safe and harm reduction approaches to care. And Felicia's developed managed alcohol, managed opiate, managed cannabis, et cetera, programs so that we can meet the needs of our patient population. Lastly, one of the other things St. Elizabeth and both Patricia and Nancy wanted to ensure was that we weren't just keeping this for the downtown core of Toronto, but how can we grow this together throughout Toronto, throughout Ontario, and throughout the country? So we do take all kinds of students throughout the year from all disciplines, and we are becoming a teaching and learning facility so that people can come learn, take the model, and bring it back to their home communities. In addition to that, we are looking at a national expansion for the program. So we have piloted in Windsor, Ontario, a 3-bed model. We wanted to see how we could scale down in a smaller community of 200,000 people. But the crisis of homelessness is just as strong in that small community. And so again, we partnered with another organization for housing, which is Assisted Living Southwestern Ontario. So you can see, and we'll speak to it further, how that working together with housing better enables us to quickly create these programs.
So I'm going to talk a little bit about the homeless population in Ontario, just to give some context as to why we need hospice services. I actually came across this information, and at the end of the presentation, there's a bunch of references here, so if you actually want to go look at the report, please feel free. I did this as part of my literature review for my PhD, started going down a rabbit hole thinking, what do you mean we don't know how many people are homeless in Ontario? Well, we really don't. So these are some very recent sources talking about the different populations of how many people are homeless to show this scale. They are quite large. There's quite a large variance between these populations as well. If anybody knows other sources, I'm not asking because I'm doing my literature review still, but if you want to shout them out at the end, please feel free. So the first one was by the Office of the Auditor General, who put out a report. They actually didn't give an exact number or an estimate of people experiencing homelessness. Instead, they used a calculation saying for every 10,000 people in Ontario, 16 people were homeless. This was for 2021, and if you did the calculations based off Stat Canada's data, that would mean 23,900 people are homeless. I then thought, well, it's 2024, so let's do the calculation for 2024 based off Stat Canada's data. Well, that would mean 25,798 people were homeless. That seems pretty low based off the shelter beds in Toronto alone, where I'm from. So I took a look at other sources. There was one that did come up, and if you Google how many people are homeless in Ontario, a large number comes up of 234,000 people. So it's like, well, where did this number come from? So I looked, and it came through a article by a newspaper who did a Freedom of Information request, and in a transition binder from the Ontario government, they quoted this number. And you can read the article, it's cited at the end. However, the journalists did reach out, and a spokesperson for Justin, I'm gonna butcher that name, I am sorry. But they came back and said that that the number was high for a number of people experiencing homelessness, that it actually wasn't 234,000, but they did give another data point that was really interesting. They said that 31,642 people experiencing homelessness in April 2024 were on ODSP and OW. So that number is actually higher than what the Office of the Auditor General stated right there, showing a discrepancy. And we know that this data point excludes all people not on income, on CPP, or OAS. So we know it's a huge undercount from there. So is this accurate? It's a good data point, but it's probably not the total number of people experiencing homelessness. So there's another study conducted by Government of Canada who did a time and point across 72 regions in all of Canada. So this is no longer Ontario, all of Canada. And they're estimating that between March 2020 and December 2022, 40,000 people are experiencing homelessness. It sounds a bit low based off just the number that the spokesperson gave out. That being said, there is a difference between time periods as well. And then a last study used an algorithm and estimated that in Ontario in 2016, that that 59,974 people are experiencing homelessness, which for Ontario, that sounds more accurate to me as well. So you can see this large discrepancy in just knowing the scope of homelessness, but we know the scope of homelessness is large and why we need services like hospice care specific for the homeless population. Just to really drive that point home, and I won't read through this one too much, but there's other data points showing that the number of people experiencing homelessness over the last couple of years are substantially increasing as well. So again, a study conducted by Richard et al. Quotes these statistics here, that the number of people experiencing homelessness during the time period within the study, the algorithm calculated, there's a calculation done to show an increase in homelessness. The study done by, or the count done by the Government of Canada estimated that, or calculated that across 67 regions between point number 1 and point number 2, there was a 20% increase in the homeless population. And again, this is across Canada, not just Ontario as well. But I will say, for fun, I calculated using Stat Canada's data during the same time period. And yes, I'm weird, I like calculating stats. What was the Ontario population growth? Well, that was 6%. So Government of Canada is calculating it at a 20% growth rate, and Ontario Stats Canada estimates of Ontario is 6%. That's a lot quicker. And then another data point I like to point at as well is, and I always bring this up, is number of people turned away from shelter beds in the city of Toronto as well. You can see this graph here, and the most recent data points that are available on the City of Toronto's website for the average number of people unmatched to shelter beds. So if we just calculate based on number of people in our shelters, that also gives us an inaccurate picture as well. And again, this number of unmatched people in the City of Toronto alone does not include people who just gave up on calling the referral center as well. So, not to be doom and gloom, but the scope of homelessness is growing and getting worse. Mortality rates in homelessness as well are also much higher. For sake of time, I'm not going to go too in depth, but these are several studies that were conducted as well, showing high mortality rates as per the studies for the population experiencing homelessness compared to the general population. And the first study looked at males in the Toronto shelter system compared to males in City of Toronto as well. I'm also going to make sure I don't go too much in depth because there are studies by Stephen, who's also here as well. All right.
Just for the sake of time, what I just want to highlight again is, besides the health equity dimension to this partnership, what the partnership really has shown is that when housing and health, to Sam's point earlier, come together, beautiful things happen, and they can happen quickly. And so in both circumstances, both the Toronto site and the Windsor site, we scaled this up in 3 months. Okay, so like in the traditional hospice setting where I came from, it could take a community up to 10 years to get their hospice operationalized. And so the ability, because the need is great and the need is now, to be able to execute quickly was paramount to this relationship. And then further, I'll let Felicia speak, but then the quality of care and the welcoming environment that our patients feel in the Homes First setting. So I'll give it over to Felicia.
So I just wanted to share that I'm so connected with just these partnerships with housing organizations because half of my career was as a visiting nurse in downtown Toronto, and being able to support really marginalized populations in the homes and seeing all of which everybody spoke about today, just the sort of disconnect with individuals who are precariously housed or unhoused, all the health conditions, the complexities with substance use that play even more of a factor into their overall health. It was one thing to see it out in the community and just sort of thinking on my own that I was doing my best to advocate for them was going into housing organizations and getting to learn and know about all of the additional supports, case management that there were to offer, and leveraging that, I think, was a lot of learning over the years. And so to come into this program with Homes First and Journey Home Hospice, sort of in more of one setting where we really look forward to referrals or find individuals out in the community and bring them into a more, I guess, stable environment, I think to me is really amazing. And so, yes, while I do have a case scenario that is so common within the patients that we support in our program, it's just really just seeing everybody speak, and it just really hones in that the complexities in working with these vulnerable populations are so many, and the skill set to look after this population are also so many. And so where, in the beginning when we were growing this partnership, where few of us thought kind of we were the jack of all trades, we were really the master of none. And so being able to collaborate together to provide actual specialized services, I think is so amazing. And I guess why all of you are here today in your major roles as advocates to do better for these individuals who really need it most. And I know we are over time, so just sort of in a nutshell, this is really a common situation that we do see at our hospice. We have often younger individuals where the community is actually advocating for them to get more stable support, not them themselves. And often they're very socially isolated. They don't have family. It's often caseworkers, healthcare workers, and it isn't a coincidence where Dr. Hwang said that often there's vulnerable populations going into the hospital with multiple ER visits. That's often when often physicians in a PCU unit are calling us to say, hey, listen, this patient doesn't meet your criteria because their prognosis is over 3 months, or they really have a chronic end-stage disease, so they're not really terminally ill, but because of their housing situation, their mortality rates are higher. Can we work together to do something for this population? And often we say, yep, that's exactly why we're here. And so this is a classic situation where we have an individual with multiple medical comorbidities, substance use issues, severe mental health issues, where there were opportunities for housing, but there wasn't that medical team to help with coping mechanism to keep them into that housing. It was often, the behaviors or the individual going out to find drugs and not coming back to maintain the place, that there was no way to really advocate for them to keep that place. So they'd lose the unit, go out, or they'd go into another facility, and the facility didn't have that skill set to keep them into their care. So then they were sent to the emergency, their bed was given up, and there wasn't that opportunity for them to go back. And so that's often a situation that arises. So for this individual, after kind of getting the phone call from St. Mike's, although I'm keeping personal health information confidential, we were able to bring them into our care. And it was also a challenge because at that time, we didn't have a big social work program, although we can always leverage from Homes First case management team, but this individual didn't have a power of attorney, and their ability to provide informed consent was iffy, and so often we went out to visit patients multiple times to build that trust and be able to establish a relationship before that individual either agreed to come into our care or whether the medical team felt that they were also, their goals of care met our hospice criteria, in that they were a DNR status and that they understood that and all of that. And that's where sort of collaboratively we are able to work with different organizations or referral sites or hospitals to help provide at least that clarity to be able to bring patients into our care where sometimes things aren't clear, and rather than sort of put roadblocks where time goes by, patients get either sick or have to be discharged from the hospital, and that's where we try and really make that happen and bring them into our care. And so anyway, our team was able to really work with the patient to build that trust and complete the required paperwork, and also work on advanced care planning when the patient was capable to do so, which plays a huge factor after patients with limited social supports or no next of kin do pass, because we really want to give them that opportunity to state their preferences, and when they do pass, to provide them with a timely, dignified funeral, because often without certain pieces of information, without family, that can take a lot of time. So we have a good relationship with social services and the Office of the Chief Coroner, and Homes First has that familiarity and experience as well, because largely they're the patients that are housed in the building don't have family or have really severed ties with family, estranged relationships, and so we're both familiar with that process. And so many challenges that we are finding our individuals do face, particularly this individual that I'm discussing for this case study, were medication non-adherence, substance use, behavioral issues, hoarding, leaving the hospice where they had no cell phone where we could call and make sure that they were safe. And so we worked quite hard as an interdisciplinary team to put an emphasis on personalizing, of course, their care, which we do for every patient, so that it is patient-centered and meets the individual's preferences and goals, and just continuously, relentlessly providing that support for them. And so it's not that they leave and they're going to go off-site and they're not back for 16 hours, that we're, oh, now, you don't need this bed, you're out and about, you're resourceful, so we're going to give that away. No, we recognize, we understand these are the complexities that come with this patient population, and so we want to work as hard as we can just to ensure that they are safe, that they feel that they're able to return back to the hospice, not be stigmatized, not be judged. And the wonderful thing about Homes First is that they really recognize that as well. And often if they see our residents that may have been out and we were looking for them, they keep an eye on them, they'll keep us in the loop, they'll call and inform us. And so we keep each other informed on that. And the other, I think, important piece with this partnership that we've taken note of is that sometimes referrals come within, and often Homes First has had patients living within their housing units for many, many, many years, and they don't want to leave that place, but there is an opportunity either for us to check in on them within the buildings or start building trust from as early on as Homes First is aware that they are declining or they have a life-limiting diagnosis, so that we can start establishing that relationship, maybe give them a tour of the hospice, show them that they will still have access to their original care team, and that often makes individuals more inclined to come into our care, where they may need 24/7 healthcare support and heavier just overall medical support. And so that's often also a relief for even just the Homes First staff who, while they may feel helpless because they may not have access to 24/7 support within the unit, there is that reassurance that if the patient is ready to make that move, that we are just a phone call away and maybe a couple floors away, depending on what building these individuals are in, to come receive that needed specialized care. And we can also leverage Homes First too. We've had individuals, it's like a Friday afternoon, the hospital discharged a patient to a Homes First building, not the right Homes First building, and we don't know what to do because they assume because Journey Home Hospice is at 90 Shooter, that's where the patient was, and so we're able to connect with Homes First to help get them into their right environment within a more timely manner, or we can help advocate and work with a hospital just to ensure that they are somewhere safe rather than sitting in front of the building door, which sometimes happens. And so I think just really want to emphasize that partnerships between housing agencies is something that I kind of grew to learn the magnitude of how important it is when I came to work at Journey Home Hospice, because this was what the program involved. And I think if it wasn't for housing organizations such as Homes First, I think the space downtown is limited, but the need is really high. And so we were able to have that space in downtown Toronto, where often patients are very familiar with. Often, we've had individuals living under the Jarvis Bridge for 15 years and they don't want to be too far from home, or they have been living at Seton House for 20 years and they, as much as individuals may think that is not the best place for them to be, that is their home. And so there is some reassurance that we are still in the community. And so there's so many unique, I think, challenges within these vulnerable populations that why not work together and collaborate and utilize the skills, expertise, experiences of wonderful advocates such as yourselves that have devoted your careers to supporting those most in need. And one other sort of shout out to Homes First is thank you for always creating that welcoming space. And anytime we do have extra complex individuals coming into our care, that you welcome them without having them feel stigmatized, so that they always come back and return, rather than us finding them in the emergency room a few days later if they've decided to kind of go out and get into some trouble. So thank you so much, everyone, for your time.
I think we've been drinking from a fire hose here, but that's the good news. The bad news is we're out of time. And I'm standing between you and lunch, which I don't want to do for very long. So I'm going to take the opportunity to say thank you for coming here. Thank you for listening. Thank you to our presenters for doing a great job. And I also want to invite anybody with questions, if our presenters wouldn't mind sticking around for a few minutes. If you've got specific questions, come on up and just talk to them. And don't knock over microphones. So thank you very much for coming, and lunch will be served in the plenary room, so that's where we're headed back.